Christine, so we can get started.
Yes, my paper is actually by our very own Dr. Tremble, and Juliana is also on this too. So why I'm presenting this, I have no idea, but here we go. Yeah, so it's discussing how primary MTD is analyzed using shear wave elastography. Oops. And what that looks like with people who have the disorder compared to typical speakers who are in voice occupation settings, like teachers, performers, singers, things like that have to talk very often throughout their day. It's a little bit of background about the paper and about the disorder. We've talked a lot about what MTD is already, so I'm not going to go into a very extensive explanation of the disorder. But like Rainey mentioned and Braden earlier, that it's tension around the vocal folds without any structural or neurological issues or any kind of physical deformities around it. And so prevailing theory is that MTD is caused by excessive tension in the external laryngeal muscles. But the current tools that are used to diagnose it, so palpitations, feeling around it, as well as like other tools, are very inconsistent and don't give a good picture about what's happening around it. And so this study will analyze how using shear wave elastography is an ultrasound technique to push acoustic vibrations to see muscle movement and see rigidity versus flexibility in vocal folds, and how that can impact people with MTD versus typical speakers. So going into this paper specifically and kind of what was analyzed and looked over. And so like I mentioned earlier, using elastography to measure muscle tension in external laryngeal muscles. And so the three kind of sub objectives is comparing typical speakers versus the disordered population, comparing the results to standard clinical measures that already exist and seeing which one is more effective and can give more information for diagnostic criteria. And then seeing kind of before and after pre and post testing with various tasks to see how muscle tension can vary before having a heavy speaking load versus after having a heavy speaking load. And so as you'd expect, the hypothesis that was proposed is that people with MTD have more tension than those without any kind of disordered or muscle tension around their vocal fold and vocal tract. And so the design within the study is about 65 people, 30 with MTD, then 35 controls without any voice disorders, but all 65 were occupational voice users, so teachers, singers, performers, so on and so forth. And so I'll go into a little bit more detail about these different measures that were talked about in the results section, but looking into how SWE went through the different 4 muscles that were focused on, a laryngoscope to have a camera looking inside and seeing how the vocal cords are vibrating, acoustic analysis to see how their acoustic sound is perceived by a listener, and then self-perception scales for the speakers of how their vocal fold effort and vocal fold sound is to them. And the conditions of the study is pre and post testing, before and after heavy vocal load, and then doing the analyses for SWE at rest and then during voicing. And so these are the 4 muscles that we're focused on: the genohyoid, the anterior digastric, the sternohyoid, and the thyrohyoid. Very hard words for me to say. And so how these things are focused on, the different roles that they play into speech and swallowing and muscle movement. And so the anterior digastric will elevate the hyoid bone, the tongue twister, which is this white little mark right here. And so this anterior is the front of the yellow. And so it helps lift the hyoid bone, and it links to muscles that are on the floor of the mouth that initiate the swallow, and it's also in jaw depression and jaw lowering. The genohyoid is this red one over here on the left side of it, and it pulls the tongue forward and upwards, and it plays a role in swallowing and speech whenever you need to move your tongue to articulate certain sounds. And then the subhyoid over here on the right side, the sternohyoid, is the blue line going down. It pulls the hyoid bone down, which is for stable position of the larynx, so allowing for movement and airflow while speaking, And the thyrohyoid is the yellow one kind of hiding behind here in the back. And it has a couple different functions. It can depress the bone here, but then it also raises the larynx. And it can pull it up to help protect airway while swallowing and also help push air during phonation and during voicing. And so you can see the results of the testing for having SWE, the tension increased for those 4 muscles during voicing compared to rest in both groups. There wasn't a significant difference between typical speakers versus those with MTD. And then there were no, and so the control groups and those with muscle tension dystonia were relatively the same, and there weren't any kind of significant clinical or statistical differences between them. Using the scope, those with MTD had higher compression than others, so there was more visible muscle tension compared to those who didn't have MTD. And then the CPP is the acoustic analysis that was done. And they had lower values and controls, which means that they had a lower voice quality, which tends to be more hoarse, more rough. For some, it might appear more breathy. And then having lower values means lower voice quality, whereas higher values means a higher voice quality or a more healthy voice, as some might say. And so the next 3 figures are in the paper, but just kind of talking about it here. This is figure 4, and so this is going into the rest versus voicing conditions. And so seeing how with SWE, you can see the blue is a control, whereas the red is experimental within different muscle groups across these 6. And so the vocalization on the left side versus the effects of vocal load here on the right. And so main findings with these, that both groups, the testing group and the control group, showed significantly higher muscle tension during voicing compared to rest. And that showed that SWE is reliable in detecting muscle activation during phonation. However, one thing that was notable is that the left thyroid muscle showed a greater increase in stiffness in the muscle dysphonia group, but it may have been to individual variation rather than a consistent group effect. And there's a lot more that needs to go into this field just because of the lack of information we have over these different diagnostic criteria. Then over here on panel B, you can see the effects of the vocal load. And so there weren't any significant differences between the control and the testing group at voicing or at rest and before or after. So kind of across the board, they were almost pretty identical. As you can see here, the lines overlap on almost all of the different sections across the muscle groups. And so the vocal load didn't really differ across either, and that wasn't a significant impact for it. So figure 5, this is the laryngoscope that was done for the participants. And so the MTD group showed significantly greater compression than the typical group. And so this was consistent before and after vocal load. So having to go through, I believe a 30-minute vocalization task. And so, but the vocal load did not significantly affect compression within severity group. Just the MTD group had always had a higher compression rate compared to typical speakers. And so on figure 6, maybe. This is the capsular peak prominence. This is the acoustic analysis that was done. And so those with MTD, like I mentioned earlier, had a lower value at pre and post vocal load testing. But it remained stable after the vocal load. And so there wasn't any change that was observed in either group. And so despite the group differences, the values for both MTD and the control participants fell within the normal range for vocally healthy individuals. And so with all of this, some different clinical implications that can be made within this is, so even though SWE didn't differentiate between the groups like traditional measures did, it suggests that the symptoms of primary muscle tension dysphonia may not be related to measurable muscle tension. And so it may reflect, tension may be due to occupational requirements, so having to speak as often as they do compared to a pathology with having MTD. And so one suggestion from these results is that MTD might might stem from sensory perception, not biomechanics. And so it might be something that is perceived by the individuals who have it rather than any kind of neurological or muscular disorder. And so even though SWE is a very accurate tool for sensing tension and for being able to identify that during phonation or during not, it still has a lot more research that needs to be done before it can be used clinically for diagnosing muscle tension dysphonia. And so this clinically, I don't really do voice therapy, so I can't say too much on it, but this might have a role in diagnosing MTD and knowing that extrinsic laryngeal muscle dysphonia and impacts that has on dysphonia may have a higher impact than what was previously thought before in clinical settings. And so finally, this kind of can reframe a little bit about what people have think about MTD in the past. And so there's not really any kind of relation that has been found, at least within this paper, that show elevated laryngeal muscle tension within MTD. And so maybe a more sensory perceptual within the individuals who are diagnosed rather than a biomechanical or a neurological aspect. Some limitations within the study that were mentioned is that the tension was only measured during sustained vowel production and pitch, not during speech, or not during cohesive speech tasks. And there was no data at vocal onset and did not capture any measurements immediately before or after the onset of voicing, which might be important for noticing tension dynamics of how your muscles activate at the beginning of voicing and phonation, and how tension during connected speech may have different patterns than sustained vowels or individual sounds in isolation. And so future directions of research should be aimed to explore different neurological and perceptual mechanisms that play a role in MTD and investigate kind of the missing aspects within the study of how this can be used in analysis for continued speech rather than just isolated phonation. That's all we got.
Questions, thoughts, comments, discussion?
Anything that I missed from the two that did the paper?
Random question about page 6,
Mhm.
about the control group. Is that normal that post vocal load? Is that showing that it's better, right?
This thing here? Yeah.
Is that
We don't know how normal it is. Let's be perfectly honest. And what you mean, why is people's high on vocal load? Maybe they warmed up at that point. The vocal load. It could also be there's some literature that suggests that if it's too much of a high CPP, it could be explanation, or go into the category of strain or phonation. So maybe they were tired and squeezing more because they were tired. So it could be they warmed up, or it could be that they were straining more.
And I feel like we never have this opportunity, but like for future directions, it is now the future from when this paper was written. Have you done some of those things?
As far as
like redoing it, but looking at the onset and
yeah, so that's next paper.
oh no.
So you mentioned that SWE type of ultrasound?
Yeah, so correct me if I'm wrong because I've never done this before, but my understanding is that's an ultrasound that's placed over whatever region you want to focus on, and then there are acoustic waves that are being pushed through to help cause vibrations of the muscles to see how stiff or how flexible the muscles are.
Propagation, the way I describe it to my participants is if I take a ball, which is the acoustic push pulses, and I throw it against the wall, the velocity at which it bounces back at me is going to be a lot faster than if I take that same ball and I throw it at a pillow. So if you have really tight muscles, it's not as the stiff wall, the velocity of those acoustic pulses come back at me faster versus the pillow loosey-goosey muscles. If I hit those acoustic pulses, it's going to come back slower. So it's a good proxy for measuring muscle stiffness with phonation and at rest.
And is that something normal ultrasound can't give you?
It's an overlaid system, so you have regular B mode grayscale ultrasound, which is what the Soul paper, the first paper showed, or second paper. And then it's like an overlaid system that sends additional acoustic pulses into the tissue from the transducer.
What is a typical range of the sound frequency they use? Oh. This makes me think it's not a muscle thing. I don't know much at all. So we all agree.
I actually had a little bit of discussion questions after the if you want to ask.
Any other questions, comments from the ideas, thoughts, suggestions for future directions?
I guess we can really ask like about the like what exactly, because we were talking about the dynamic assessment, like how are you, yeah, what exactly is going to be different, but I guess yeah, we can talk about it as much because it's going to be future study.
I'm sorry.
So I guess what exactly are we changing from this study was, yeah, what
She's asking like what's going to be like the scope of the future studies.
So the optical flow study, which we'll talk about next, you're alluding to, and then we did some other different methods. So there's actually other methods we applied in the